Good morning and welcome to the Sunday Breakfast tea session. This is being conducted under the auspices of Forum of Cardiac Anesthesiologists. And today we have very important subject. It's a bit new. The recent interest in left atrial function assessment has been talked about in the academic circles. And to deal with it, we have two eminent cardiac anesthesiologists of the country, Dr. Sridhar Joshi and Deepak Borde. And I request Dr. Sridhar Joshi to introduce Deepak and then take it forward.
Thank you, Dr. Muralidhar, sir. You can hear me, everyone?
Yes, we can hear.
Yeah. Good morning, Dr. Muralidhar, sir. It's always an honor to do these sessions under you, and every Sunday morning you make sure we all learn a few steps here and there. Thank you very much for the occasion. I would like to introduce Dr. Deepak Borde. Deepak Borde is a consultant at Ozone Anesthesia Group in Aurangabad. Extensive experience in cardiac anesthesia over 12 years, spanned with international and national publications. And like Dr. Muralidhar was rightly mentioning, an internationally acclaimed perioperative echocardiographer and a cardiac anesthetist India has with us right now. His special interests are risk stratification in cardiac anesthesia and POCUS. He has won Janak Mehta Award 3 times in IACTA on 13, 14, and 16, and he has been a respectable editorial board member at ACA and JCVA. Deepak has a keen eye of looking at the heart through the window of the left atrium, and he's going to express more about it through his topic today. Left atrial strain, a promising single index parameter to look at left ventricular diastolic dysfunction. Deepak, without much taking out your time, I want you to start over and take this session further. Thanks.
Very good morning to everyone, and this is really an honor for me to present something in my own forum of cardiac anesthesiologists, Bangalore. It is like my second home, and I always feel the warmth of people around me. And thank you, Kanchi Murlidhar sir, in particular, for this initiative. And I have been uh, listening to all the previous talks on a Sunday morning, and I really feel the privilege to talk on this very new topic. I think a couple of weeks back, Dr. Nilesh Duvekar sir had talked on basics of all diastolic function and which all parameters are important, and how to actually do all these parameters in the perioperative period. But I would like to take it just one step ahead and would like to tell about what are the unmet needs of this perioperative diastolic dysfunction guidelines. What all are the left atrial mechanics which we can evaluate, particularly through strain. And somebody who has not yet started doing left atrial strain, how to actually do it step by step, and what is the current evidence of utility of left atrial strain in diastolic dysfunction guidelines. And I'm very happy to share with you all our recent study which was published in JCVA last year. I would discuss that at length with you, what all things we did and what all are the future perspectives of left atrial strain management. So, so there is no need to emphasize to this eminent all the listeners that diastolic dysfunction is very common, and it predicts the worsening grade of diastolic function predicts worse outcome after cardiac surgery. And if you see this particular multivariate model, the diastolic grade was very, very important negative predictor of outcome after cardiac surgery. And this can be independent of left ventricular systolic function. So this group from Canada had studied more than 5,500 patients, and they divided patients in four different groups with left ventricular systolic function and left ventricular end diastolic pressure. So they differentiated patients in four groups, and the patients who had got reduced systolic function as measured by EF and higher diastolic pressure, that is essentially what we want to do with diastolic dysfunction grade. So if those patients, they definitely do worse in all of the four groups. So this is a very familiar but very complex algorithm to come to a conclusion about diastolic dysfunction grade. So essentially, we do assessment of diastolic dysfunction in light of left ventricular ejection fraction. Those patients who have got normal LVEF, we usually tend to measure four different parameters. That is average E by E prime ratio. E being the mitral inflow velocity, and E prime average being septal and lateral E prime velocity as measured by tissue Doppler. So second parameter is either a septal E prime less than 7 or a lateral E prime less than 10 centimeters per second. In addition, we measure the tricuspid regurgitation velocity if it is less than or more than 2.8 meters per second. And another very, very important parameter, that is LA volume index. So LA volume index is considered as the HbA1c of the diastolic dysfunction. So you can measure the long-term impact of any diastolic dysfunction by LAVI. And if LAVI is more than or less than 34 ml per meter square, so that is the cutoff given for all these four values. So if you have got less than 50% positives, so essentially there is normal diastolic dysfunction, and if there are more than 50% are positive, you have some or other kind of diastolic dysfunction. But if two are positive and two are negative, you land up in an intermediate grade. But when the patients have got reduced systolic function as measured by reduced ejection fraction, then the algorithm gets little bit more complex. So then you have to measure mitral inflow velocities and come to a normal LV left atrial pressure if the E by A is less than or equal to 0.8 and E less than 50. And if you have got a E by A ratio more than 2, then straight away patient goes in grade 3 diastolic dysfunction. And for grade 2 diastolic dysfunction or an intermediate grade, you need all other parameters in conjunction and you come to a conclusion. So essentially what we want to come to know as a perioperative physician or as an anesthesiologist is whether the left atrial pressure is increased or not. So if the patient has got grade 2 or grade 3 diastolic dysfunction as assessed by these various parameters, then the left atrial pressure is increased. So definitely everyone will agree with me that this is very complex algorithm. You need to measure ejection fraction first. It is very time consuming, and if you have got these values in front of you, or if you are very good in remembering the numbers, then only you can apply this. If you give it to a random person, it's very difficult to remember all the cutoff values for this multiple parameters. And there are significant number of patients. Various previous large population based study or patient based studies have said that significant number of patients, they'll end up in an indeterminate grade. So you don't know what to do with this, whether the LA pressure is normal or lower or higher. You don't know about it, and that is the and probably those are the very crucial subset of patient where you are very much interested in this. And another most important limitation as far as perioperative period is concerned are these guidelines are not focused for surgical patient, whether it is cardiac surgery or non-cardiac surgery. So in the guidelines it has been very clearly said that you cannot apply these guidelines into surgical practice. So there is an unmet need for a single parameter uh, which is less time consuming, which can guide you a quick assessment, and which will not have any indeterminate grade. So this parameter can give you whether you are dealing with a normal LA pressure or left ventricular end diastolic pressure or not. So there is definitely this unmet need. So uh, what are the parameters that are coming up with this? So we have always been knowing about left uh, atrial volume indexing, but more important than left atrial volume indexing, or a more dynamic parameter, if you can say like that, is the left atrial function using the strain imaging. So strain imaging is very in last almost 5 years there is plethora of publication about left atrial strain measurement. And left atrial strain measurement divides the left atrial function into three essential categories. That is a reservoir function, that is the filling of left atrial function during LV systole. So how much it is getting filled. So that is LARS, that is reservoir function, that is, or PALS, that is what we are measuring. So this is the basic parameter that is very essential, how the LA is getting filled during the LV systole. How this LA is emptying in early phase, that is measured as a conduit function of the left atrium. And whatever is the LA contraction that is contributing to the stroke volume, that is essentially a pump function of the LA, or the contraction strain of the LA. So now we'll come to know how to do this LA strain measurement. So you can do LA strain measurement. Most common method up till now is using the LV strain packages themselves. Or now many of the newer machines are coming with the dedicated left atrial strain measurement parameters. GE has come up with one, then Tomtech, and I think Philips also has come up with a dedicated left atrial strain uh, packages which are coming up. So if that is not available with you, not a problem, you can use it still with left ventricular strain packaging method. So what you have to do is basically you have to get an LA focused view. So the LA focused view is little different from our routine apical 2 chamber or 4 chamber view. Here our focus is the left atrium. So you have to get the best left atrial focus view. You have to narrow the image sector. You have to check for artifact free visibility of LA wall. So entire LA wall you have to trace, and you have to acquire 3 to 5 consecutive beats. Then contour LA is done as per as the routine semi-automatic features. You have to reduce the region of interest, ROI width you have to reduce, because this package, if it is used for LV measurement, it will have a wider region of interest. So LA being a thinner um, uh, chamber, you have to reduce the ROI width, and you have to check for tracking result and contour if needed. So I'll just give you an example by using the EchoPack machine. So now you have acquired a LA focused 4-chamber view. You are gone in there, and now you will trace the LA cavity entirely, and now you will reduce the region of interest width is reduced. So because it is a thin structure, you get all the 6 segments there, and you get a this kind of trace. So you have to remember that LA strain is always in a positive parameter, not unlike a left ventricular strain, which is a negative parameter. Okay, so you get a nice contour of LA strain. So if you are fortunate enough and you have got a Tomtec machine with you, that is a dedicated left atrial strain measurement by Tomtec. This is a vendor neutral dedicated, and you get multiple parameters. You get ejection fraction, you get fractional area change, endo and endo GCS and endo GLS. So you get this kind of tracing, and you can measure the left atrial strain. What we are usually interested in, this number 36.47, that is endo GLS. Okay, so as we were saying, the reservoir function is the left atrial strain, which we measure. So that is the filling of the left atrium during the LV systole. And then the pump function is usually that corresponds with a P wave on your ECG. So that is the left atrial contraction. Okay, so that is the left atrial strain active, and the other one is the conduit function, or that is the left atrial strain passive. Okay, so if when you are dealing with LA volumes, you get other parameters like ejection fraction or emptying fraction active and passive. So in addition to left atrial strain, you can measure the left atrial strain rate as well. And the most important left atrial strain parameter is usually corresponding to the active contraction that corresponds to the P wave, and that is represented by SRA, that is left atrial strain rate. So what about some reference values of left atrial strain? So NOR study was basically expanding up to entire European population, and they have come up with some numbers in which the left atrial strain reservoir function here is around 40 to 45%, 36 to 48 to be more wider, and the active or the pump function is usually 13 to 20 percent, and the conduit function is usually 20 to 30%. So another very important study is the World Alliance Societies of Echocardiography, that is VASE normal study. So this study has enrolled more than 2,000 patients across 20 different countries, and they have come up with normal values for men, women, according to their ethnicity as well. So they have come up with 2D measurement of left atrial. This study actually was published in just this February 2022 of Jay's journal, and they have come up with 2D parameters of left atrial strain, the left atrial length, the area, and the biplane Simpson volume method. Then they have come up with 3D LA volume. So 3D LA volumes, they have come up with a normal number, and more essentially they have come up with 2D LA strain measurement. Okay, so most of the volume parameters are lower in Asian population, but fortunately the strain parameters have remained similar across all the patient populations. So we can use the Western data in our country patients very conveniently. Okay, so they have come up with similar numbers, 42 plus or minus 10 as the left atrial strain rate percentage, conduit being around 20 plus or minus 10, and booster function around 17 or 18. Okay, so now coming up to the evidence saying that left atrial strain is useful. So this was one of the first study, probably published almost 5 years back in JACC cardiovascular imaging by Dr. Roberto Lang and his team. What they have done is they have studied almost 200 patients, and they have given grades of diastolic dysfunction, and they have measured peak left atrial strain in normal patients, grade 1, grade 2, and grade 3 patients. So as you can see here, as the grade of diastolic dysfunction worsens, the so as the left atrial peak strain rate. So you have come to a conclusion about normal or abnormal grade of diastolic dysfunction by various measuring various parameters. But the left atrial strain is one single parameter which reduces in a linear fashion as you go with the reduction in the left atrial strain. Okay, so there is another very good study which is there in International Journal of CV Imaging, and they have what they have measured is they have directly measured LVEDP, and they have measured all the parameters by diastolic dysfunction criteria or the guidelines, the extensive measurement, and they have said that if the patient has got a normal LVEDP 9 in this one particular patient, the peak left atrial strain is 41%. That is almost normal. Okay, so based on these various conclusions, they have come up with one grade of diastolic dysfunction. They have measured second parameter as the LVEDP as a direct measurement and the left atrial strain. So if the LVEDP is low, the peak LA strain is essentially normal or on higher side. If the left ventricular end diastolic pressure is 19, as can be seen here, the maximum TR velocity 2.5, the LA volume definitely significantly increased, the E by A gone very high. So this patient clearly, based on all these four parameters, you can know that the LVEDP is on higher side. So LVEDP measured directly is 19 millimeters of mercury. And in contrast to the previous patient, you can see the peak left atrial strain has drastically reduced to only 6%. Okay, so but the essential role of left atrial strain comes in this particular category of patient in which there is an indeterminate grade of diastolic dysfunction. Indeterminate grade here is mostly because you cannot measure the tricuspid regurgitant velocity. Okay, so based on the conventional diastolic dysfunction parameters, you will label this patient an indeterminate, and perioperatively, if the cardiologist has given you report as an indeterminate, you are confused what to do with this patient. How should I manage this patient? But when they measured it direct LVEDP, that was essentially normal, 5 mm of Hg. But the when you measure the peak left atrial strain, it has given you definite clue that this patient has got a normal LVEDP. Okay, so that's how the left atrial strain can, whatever is the missing block in the present guidelines, the left atrial strain can act there. Another very good study from Dr. Matteo Camelli from Italy, and they have said that if you have measured, if you are trying to look for the LV filling pressures or the LV EDP by E prime ratio. So probably up till now we have been using this ratio as the most common one to measure the LV EDP. But the E prime ratio had shown the area under curve of only 0.68. So just fitting in there. But look at this global left atrial strain measurement, and that has given you very good area under curve. So area under curve above 0.9 is usually said that this particular diagnostic modality is having excellent prediction about the parameter. So in this case, it is LVEDP. So global left atrial strain area under curve very high, 0.92. It can definitely give you a idea about LVEDP. Okay, so another study in which they have said that if you differentiate patients based on the ejection fraction, and if you have measured the E by E prime and global left atrial strain, so the left atrial strain performs very good across all the parameters. like across all the grades of ejection fraction, whether it is normal or whether it is significantly reduced as a EF less than 30% in this case. So it has got an excellent correlation, and you can see a straight line coming in there. Okay, but when you differentiate patients based on ejection fraction and major E by E prime, in a reduced EF population, that usually doesn't give you a very good correlation. So if you have to clearly, now the evidence clearly has suggested that if you want to, previously we were using E by E prime as the commonest method to use a quick come to a quick conclusion about diastolic dysfunction grade, and that has now been clearly replaced by left atrial strain. Okay, so another similar study, but they have studied all the three different parameters of left atrial strain, that is reservoir function, contraction function, and the conduit function, and the E by E prime was only 0.59, which is just barely giving edge above the chance event. But look at this strain rate, left atrial strain, reservoir strain, and it gives you a area under curve above 0.9. Another very important use of left atrial strain, being it is very dynamic parameter of the left atrial function. The left atrial volume, it takes very long time to change, but the left atrial strain pattern, it gives you very good dynamic function of the heart. So so this patient who is admitted with a frank heart failure, with pulmonary artery wedge pressures of 31, and he has got a very significantly reduced left atrial strain, I'm sorry, left atrial strain, that is reduced to only 5%. So now you have started administering him a decongestant therapy in hospital. The patient settled. The wedge pressure has reduced to 18, or not normal, but at least coming towards normalcy. And the left atrial strain has slowly started picking up. And if you assess the same patient after 6 weeks, his left atrial strain has increased to 18%. Not normal, but at least it has come to. So you can do a serial measurement of left atrial strain, and you can monitor what is happening to the therapy which you have given. Another parameter which is coming up is the left atrial filling index. So left atrial filling index is essentially the E, that is the mitral inflow velocity divided by left atrial strain ratio. So these two parameters, if you obtain, you get this kind of parameter, that is LA filling index. And they have said that using invasive methods and using this 2016 guidelines, so the authors have come up with a cutoff number of 3.27. So E by LA, so that ratio of more than 3.27 has got very good sensitivity and specificity to save for the higher LVEDP. So all in all, lot of evidence now is gathered all around the world saying that left atrial strain is very useful parameter in predicting the LVEDP or higher left atrial pressure. So that is what essentially we want to measure. Okay, so in this state of art review, if you can see various parameters that are used for grading the diastolic dysfunction grade. So you can see here the left atrial volume index, as we have said, that it takes quite longer time, and the left atrial volume index increases quite late in the course of diastolic dysfunction. Okay, so that is not useful in picking up the early patient. The E by A, the famous parameter we all know, has got a bimodal presentation. So that becomes almost a sort of normal in when you are in grade 2. So you can't differentiate basically based on E by A, because you don't know if this is the number. It can be at the normal end, or it can be just early grade 3. So you cannot measure exactly based on E by A. E by E prime also has increases in the late phase of diastolic dysfunction grade. But if you see the left atrial strain curve, so it essentially linearly it reduces as the grade of diastolic dysfunction. It starts reducing quite early in the course, and slowly as the diastolic dysfunction grade worsens, the left atrial strain reduces. Okay. So another thing can be left atrial strain can be a mirror image of LVGLS. So now coming to the our own paper which was published in JCVA, and we have also tried to all this background evidence in mind. So we thought of assessing the left atrial strain as a single parameters for predicting LV diastolic dysfunction grade and elevated left ventricular filling pressures in patients undergoing off-pump CABG. So we studied 60 patients. The cardiac anesthesiologist in the pre-operative assessment actually obtained all the diastolic dysfunction parameters, and we assigned them as normal grade 1 or grade 2, grade 3 based on all these guidelines. And what we observed here is the left atrial strain reduced in a linear fashion. It was 28 plus or minus 8 for normal grade, reduced to 21 in grade 1, 15 in grade 2, and 12 in grade 3. So it significantly reduced as the diastolic dysfunction grade reduced. So all other parameters, conduit function, contraction function as measured by left atrial strain, it also reduced in a linear fashion, and so was the left atrial strain rate. So strain rate significantly, so this is strain rate and contraction. This gives you a function about the left ventricular contraction function, so that was also significantly reduced. So when we assessed any grade of diastolic dysfunction uh, as measured by left atrial strain measurement, and we obtained an area under curve of 0.87. But when we differentiated patients based on grade 2, grade 3 versus normal and grade 1, so that is elevated left ventricular filling pressure, so the area under curve increased to above zero point 0.9, so it was 0.92 actually, and we could very clearly differentiate patients whether he has got an elevated left atrial pressure or LV filling pressures based on the left atrial strain. So we obtained various parameters here. And another very important finding of our study was whether the patient has got ejection fraction above or below 50%. So normal LV systolic function or not, the area under curve remained essentially significant. So you can very well differentiate patients irrespective of their ejection fraction. So earlier, if you had seen, the E by E prime actually fails to differentiate patients in LV reduced LV ejection fraction. So here we did not find that trend, and irrespective of the ejection fraction, the left atrial strain gave us very good parameter. Okay, so just to give an example, this patient who has got an inflow measured E by A 0.9, a good lateral E prime of 10, lateral E by E prime 6.7, average E by E prime normal. And if you see the LA volume index only 17, essentially normal. So all these parameters suggest that this patient has got a normal diastolic function. And when we measured the left atrial strain, it was 35% in this particular patient. So it definitely, a single number gave us idea about all these parameters which we are measuring. In contrast, the patient who had got a very high PA pressures, the TR velocity 3.6, higher left atrial volume index around 37 in this case, reduced septal and lateral E prime, higher average E by E prime. Remember this cutoff of 14, this cutoff of 34, and this cutoff of 2.8. So rather than remembering all these parameters, if you can just do a left atrial strain measurement here, and it was significantly reduced to 17%. So we concluded that in patients who are undergoing off-pump CABG, cardiac anesthesiologist could successfully measure the left atrial strain. This can be used as a single most parameter, and if you have to remember one number, the left atrial strain measurement less than 90% significantly predicted LV higher LV filling pressures. So, but all these parameters up till now that we have discussed, all these studies were essentially transthoracic studies. So what about transesophageal echo? So always it has been said that you cannot completely obtain left atrial borders in transesophageal echo. But now there is some evidence, early evidence from this one particular group from New York, and they have, although this was a retrospective study, not very, absolutely not very well designed, but still the authors have measured intraoperative transesophageal echocardiography. So what they have done is, in the pre-operative phase, this was measured by transthoracic echo in say apical 4-chamber view, and in transesophageal they have obtained a sort of deep transgastric view or transgastric 5-chamber view, because you can see the LVOT here, and they have tried to get the entire LA in picture, and they have measured the left atrial strain using transesophageal echo. So what they have come to a conclusion, that the left atrial length has got very good correlation between thoracic and transesophageal measurements. So the left atrial area as well was performing very good when you are measuring the transthoracic versus transesophageal. There was also good correlation between transthoracic and transesophageal left atrial strain, as you can see here, but the limits of agreement were quite wide, meaning that the left atrial strain measured by transesophageal echo was statistically significantly lower than that of as measured by transthoracic. So you cannot interchange the values. So if the limits of agreements are very wide, you cannot interchange the values, although they are going in a linear fashion, that as one parameter is decreasing by transthoracic, same is with transesophageal, but they cannot be interchanged. Okay, so what are the potential future perspectives of left atrial strain? Left atrial strain will surely find a place in future diastolic dysfunction guidelines. So there are early studies using transesophageal echo, but they are not fully validated. And we still have to measure effect of various therapies like decongestion, diuretics, probably balloon pump on in the perioperative period. So we have to be doing some activity in that area, and effect of various anesthetic medications also. So which agent is better in when you are trying to induce a patient with left ventricular diastolic dysfunction? So that needs to be still studied. And most importantly, the impact of left atrial strain on large long-term studies, that is still not yet been done, and that too with a prospective enrollment are very much warranted. Thank you very much.
Sir, Muralidhar sir, your comments, please.
Yeah, very nice presentation, very educative. All important points were brought in, very nicely presented. I just wanted to ask you one question before we open up the discussion with others.
Yes.
What happens to patients with atrial fibrillation now? How well is it going to interpret the diastolic dysfunction in
Yes, sir.
patients who have left atrial fibrillation?
Excellent question, sir. Thank you for that, because I have not included that in the presentation because but left atrial strain has been studied in patients with atrial fibrillation also. But what happens is you will not get all the three phases of left atrial strain. You will miss the obviously the pump function or the contraction function, because that is absent in patients with with atrial fibrillation. But the left atrial overall strain, that will definitely give you an idea. So in this difficult subgroup of patient in atrial fibrillation, we are very confused how to grade diastolic dysfunction.
Right.
Probably
Yes.
in that area also, the left atrial strain can be useful. Thank you, sir.
Thank you. Thank you for that.
Good morning, sir.
Good morning.
Good morning.
Good morning, sir. Hi, Deepak. Nice presentations about
Thank
new recent speckle strains about the left atrium and reflects the left ventricular functions. Just I wanted to ask what happens in patients with mitral stenosis or MR? Then suppose if the patient has got VSR and all, shunt is there, VSD. So is it same or what? I wanted to ask the same AF, like what happens in mitral stenosis or MR? Would you like to? Can you understood my answer question? Hello.
Hmm.
I think Deepak has lost his connection. Deepak, can you hear us?
Deepak, are you there? Deepak, are you there? So the question is about
Hello, sir.
mitral valvular lesions. What happens to strain?
And in the stents fractions, whether this these trains and all will be only for normal function chambers only you assess, or even for other mitral stenosis or regurgitations or VSDs. The other question is in appendicular LA appendix, where it reflects whether it reflects you the strain studies early, whether the thromboembolic episodes only velocity, we know only velocity for 40 centimeters, and less is the precipitating factors for thromboembolic this one phenomena. Is
Can
there
I-
any, it gives like that?
Can I add on something here, sir? Prabhu Shankar sir, with your permission.
Yeah,
Sorry.
please.
So
You are
coming
the
to the last
moderator.
question, going on with whether left atrial appendage is, does it reflect anywhere the LS strain function, or does it add anything more? There has at least been 2 studies that come back to us when we were going through our paper, is a comparison of left atrial appendage strain versus the left atrium overall strain, and do they represent each other? Does one predispose earlier or not? There was very good correlation. Those 2 papers mentioned a very good correlation between the strain of the appendage and the strain of the overall left atrium. So in situations where you probably could not get a left atrium complete wall, like typically happens in an transesophageal echo interrogation, is assessment of only appendage enough? The answer to this particular question was a yes from those 2 papers, that left atrial appendage reflects the same strain of the left atrium overall. So that part answers the last question, I guess. But again, only 2 studies. We have to go back and see more of it. The other parts, like
About in the regurgitants,
like mitral regurgitation for that matter, overall strain of the left atrium in situations where the septums are intact, that is the situation where it has been tested so far. It's always been tested in situations of adult populations where there are no intracardiac shunts, to be very particular. There's no data of, as I understand, or I have gone through data about intracardiac shunts and left atrial strain. So in patients with mitral regurgitation, the left atrial strain will continue to reflect the left ventricular end diastolic pressure when it comes to the function proper. Of course, the volumes will change based on the chronicity of the mitral regurgitation. But when it comes to strain, I believe it entirely reflects the left ventricular end diastolic pressure. I'm not sure, I cannot extrapolate the understanding to a situation of mitral stenosis. I'm really perplexed myself either. I'm not sure in mitral stenosis, how does the left atrial strain
because
respond?
LA will be always filled up.
Yes, so the
Strain.
volumes
Yeah,
go up, but I'm not very
Volumes.
sure how the strains respond, because I have not come across any such literature. Neither have I done anything in mitral stenosis in per se. So that question
can I
remains
add
open, I guess.
another, Sridhar?
Yeah, Deepak. Can you hear us, Deepak? You're back?
Yeah, I'm back here.
Yeah.
Can you hear me? Yes, now.
Yes,
So
yes.
another very difficult population which can be there is the annular calcification. So you cannot completely trace the LA borders. In our typical rheumatic patients, where there is a lot of annular calcification, you cannot trace the complete LA border. So that can be a problem. But as far as the ischemic mitral regurgitation is concerned, I think there are studies available, as you correctly pointed out, and we can definitely use that in patients with mitral regurgitation, which can be ischemic or a degenerative. So that can be definitely useful. Yes.
Murlidhar, can I say
Yes,
something?
please. Yes, please.
Yes, please.
Deepak, excellent as usual. And I am out of Pune in one of the resorts, and I have come here to relax, but couldn't resist attending this lecture. That is the power of you and
No,
power
thank
of
you. That,
Narayana Rudayalaya breakfast session.
that is so kind of you, madam. Thank you.
Continuing Dr. Murlidhar's question, I'll just make my video on. Can you? Okay, he had asked about atrial fibrillation. Okay. Here is my sub question that which of these three, reservoir, conduit, and contractile, which one is more important?
Madam, the most extensively studied is the reservoir function. So that can be useful.
Which is
The
more important? Which is
reservoir.
more sense? Huh? So
Reservoir.
when atrial fibrillation is there, you can certainly go by reservoir, isn't it?
Yes.
So naturally that answers Dr. Murlidhar's question. And
Yes.
I have a couple of questions. Can I go ahead?
Yes, please.
It was a very excellent, and I'm looking forward to doing it, and I'm doing it in Jahangir, but in my private scenario, I'm still I have to set up it. But when there is extremely mobile interatrial septum, which we many times we come across, so how do you manage that? Another, I will answer all the, I will ask all the queries first, and then you answer them. Second is septal dropout. That is also many times we come across. And how do you manage contamination by pulmonary veins, atrial appendage, and if there is thinned out fossa havalis? So how do you manage certain situation? And last, how to take exactly this focused LA view? You know, it will guide all of us to measure it properly.
Okay, so I'll answer the questions one by one. Try to answer because the questions are really difficult, as you always ask difficult questions. Uh, if you are having a problem with the mobile or the interatrial septum dropout, another simple trick that I can imagine is you obtain a two-chamber view. In two-chamber view, this question can be nullified. So in two-chamber view, you can trace if there is a septal dropout or mobile septum, you can probably exclude that in your two-chamber view. Okay, and when we are measuring the left atrial strain, similar to left atrial volume, when we are measuring the left atrial volume, we have to definitely exclude the left atrial appendage. We have to exclude the pulmonary vein coming into the confluence there. So we have to exclude all these parameters. So that essentially remains the same as the left atrial volume measurement. So we can definitely do that. But for obtaining a left atrial focused view, so if you can see it here, the left ventricular focused view is usually towards the apex. So this way, but left atrial focus view, you have to basically obtain a zoom view of the left atrium, and you have to obtain it as maximum as you can.
No, but they say you don't zoom LA while doing strain. That is the guideline.
Zooming is focusing on the left atrium. Zooming means not physically doing it. You focus on the left atrium.
Here, it's a small tip actually. If
Yes,
you foreshorten the LV little bit,
yes,
you
then
will
you
get
obtain.
focused LA.
Yes,
That,
definitely. Yes, absolutely correct. Absolutely correct.
Can I go ahead with another question, Dr. Murlidhar? Otherwise, anyone they want.
Absolutely. Dr. Vinayak has raised his hand. Can I ask him to ask his
Yes,
comments
yes,
and
yes.
then
Please,
go
please.
for...
No. Thank you, Dr. Murlidhar. I have just a comment that the
Yes, please.
interaction is excellent, no doubt about it. But it should not put the speaker always in trouble. Because you are why I'm saying it is because you are asking something in a evolving science. So
Yes.
you have some questions in your mind. So this
Yes.
forum is to stimulate you and try to do your research on your own. It is not that every answer you will get in the forum.
No. But the thing is,
No,
if
no.
the
So
expert has an answer for our doubts, he or she will be able to clear it off.
perfect.
So
That that's not a that's not a
that's the only thing. It is not to
yeah.
uh, not
Actually, it is to stimulate
lead
all
somebody
our
else.
brains.
That's the
Yes,
plan. So
It
people should
is.
also
absolutely.
do some research following these talks.
Yes.
Yes, absolutely. Now, Sanjeevani, please carry.
See, there is one uh, uh, how to take the subtle LA dysfunction, how to reveal it. So, how we do stress echo on LV side, the strain is also coming after exercise. So, are you able to enlighten on that?
Sorry, madam. As far as the stress echo is concerned, I have got no
No,
experience.
not stress echo. LA
Mhm.
strain after exercise. Many a times LA may be normal at rest, LA strain,
Okay.
but sometimes you can reveal it after giving it a bit of exercise. How we do exercise diastolic dysfunction, just like that. So,
No, actually, I'm not aware of such maneuver. I'm sorry.
Sir, sir, Deepak, this
Yes.
one we don't have formula to assess. Some machine have got the prefixed formulas for the assessment. How to for to assess the strain. We have a ordinary this one where don't have any this one prefixed formula for the assessment of strain. What are
Uh,
all the factors to be taken to for the assessment? You understood my question?
no, actually, you mean you don't have the software to do the strain imaging?
Software, yes.
No, sir. Then definitely software is mandatory because you can't do it unless you
Okay.
have got the software. But I think
Because
whichever machine you have got, you can contact
hmm,
the vendor, and I
hmm,
think the vendor will be more than happy to provide you with
okay,
the
okay.
software. Although they usually come with the newer machines pre-installed, but if like in my I'll tell even my own experience because we have got a GE machine which is T8, and unfortunately when we bought the machine the hospital did not have the put in the software, but the GE people were very kind enough to give me it on my laptop. So if you can contact one of those vendors or the representatives, you probably can get it for sure.
Just one more. It's a silly question. During intraoperative period, beating this one,
Yes, sir.
can you have? Can you assess because it's all pre-op assessment and all. Can
No, sir.
you?
Definitely, sir. Definitely, this is important question because this question was on my mind since I started doing it on transthoracic echo. So, can we
Hmm.
do it in transesophageal echo? I think Dr. Kedar also has asked the same question. Is it possible to do LA strain by using TE? So, LA walls are not very clear in your mid-esophageal windows. So, what you need to do is you need to go in deep transgastric, rotate it little bit to the right so that you get aorta in your picture and you get the left atrial in the full that the same one which I had shown. There is that paper in JCVA which has measured left atrial strain using deep transgastric or transgastric 5 chamber view. With use of TE, it is definitely possible.
Yeah.
I have done it myself in 10 or 15 patients, and definitely it is possible to see the entire LA. So idea is to see the entire LA, and then you can do the left atrial strain measurement by using
Can I
this.
add here?
Good. Thank you,
Can I add
Deepak.
something here, sir?
Oh,
Thank you, sir.
yes.
Sir, strain is entirely angle independent. So the concept that it should lie in line with your axis or your ultrasound Doppler doesn't exist. So no matter how you see a structure, it will give you a strain between 2 points in the wall of the structure that you're trying to look at. So it's not angle independent. That brings the independence or the freedom that we can try it in different angles and different views. That's where the concept came in TE, should we do it? Like Deepak rightly said, we did a few cases as a pilot one when we saw in transesophageal, we saw good correlation. By the time we progressed on to do it live, we had a paper coming up in JCV already. So it's an angle independent. It's an angle independent one, so it can be done in any views. One very subtle point I want to make, which probably covers most of the questions here, is there been a lot of questions coming in where, when appendage comes in, when pulmonary vein comes in, when the PFO is there, the interstitial septal is moving, how well strain behaves. I think I'll have to put it in one subtle way that this is a global strain and this is not regional like the left ventricle. So it doesn't take into component one particular part of the left atrial wall and tell you how it is. So it's the strain that the overall chamber is going through during different phases of the cardiac cycle. So if there's a pulmonary vein coming in and that wall doesn't come in, the strain of that part doesn't come in, but it still reflects overall the left ventricular wall, left atrial chamber wall strain. So even if there are a few lacunae in tracing up completely, it might not nullify the strain completely or precisely take it out of the clinical scenario. It still gives significant input into the decision making of how the LA strain is. So I think it's too harsh, I mean, to begin with, to call about LA strain saying I cannot take the whole of the LA, parts are missing, pulmonary veins are coming, the flapping intraatrial septum, will it just divide the value that it adds? So my
No,
suggestion is it still continues to be global and we should appreciate it with small lacunae around till we have a precise answer.
Absolutely valid point, Sridhar. But what I would like everyone to probably, I would like to suggest that you do it yourself first, and you will come to know how easy it is. So we have been struggling with diastolic dysfunction measurement in a big way. We always think that somehow we can't do it in this. So if you have got the software, it's very easy. Essentially, you just have to get one 4-chamber or 2-chamber view. You just the most of the, if you have got automated softwares, it can measure it very clearly. So it's just matter of fraction of seconds to measure the left atrial. It's not difficult at all. It's not difficult.
All these questions were discussed extensively. These hurdles, these mental lacunae, these mental walls came up to us when we started doing all this. So as we did it, we realized, doing is the only solution to it. That's what I'm sure Deepak means.
So, and probably, as Desurkar sir said, probably if all of us start doing it, probably it will stimulate more ideas, and we will come up with our own questions. And probably to find the answers of these questions is the interesting journey. So probably you need to sort of explore it more and more in various patient populations, and then you will come to know about its utility. So we are still in early phase of this, and if we can do it more often, then we will come to know more about it. Thank you.
So I guess most questions in the chat box were answered as we discussed. More was discussed beyond the chat box as well. So I think we are done with the discussion. So your final points to end the session.
Thank you, Deepak and Sridhar. It was a very good quality presentation followed by discussion. And it's a new concept. It may not be so new to you, but for most of us it is new. And I think, as you Sridhar said, if you do it, you will get the mental block out, and you know what it is exactly and how to interpret and how to utilize for the best interest of the patient's care. Thank you so much. I leave you to enjoy your Sunday, and we'll meet you again next Sunday with another topic. Thank you so much. Thank you for all the participants, Sanjeevani and others who have participated, Dr. Vinayak Desurkar, Prabhu Shankar, and the Forum of Cardiac Anesthesiologists of Bangalore. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank
Thank
you.
you.
Best wishes.
And hope we can meet in Madurai. Thank you.
Thanks, Deepak. Bye.